Hey everyone, it's Dr. Joby, and welcome to the second episode of Tell Me About Your Specialty. I'm here with Dr. Ramon King, a second year internal medicine resident in a private hospital from Makati. So, Ramon, can you give me a quick intro of what you do right now?
As Dr. Joby said, I'm a second year internal medicine resident in a private hospital in Makati. So, as a resident in internal medicine, we handle a lot of cases, all under the general subspecialties that you can think of that internal medicine handles, such as cardiology, nephrology, pulmonology, and etc. I'm just a newly graduated first year. I just got into my second year now. From my first year of internal medicine, we handled mostly the ward. We didn't handle yet the emergency room or the ICU, but during my time, I guess it was a bit special. It was the year of COVID, so we did handle also the COVID wards or COVID floors, if you put it, um, which some would describe as a mini ICU at the time because a lot of our patients were intubated or unstable. So that's more or less what I did during my first year.
Wow, that's a lot to take in, especially you started when the whole pandemic also started. Doc Ramon, how would you describe the experience in the COVID wards compared to regular wards?
It really depends when you talk about it. It depends if you talk about the start of COVID and where we are right now. At the start of COVID, it was, as you could expect, it's actually it was very scary at first. Entering a ward that's supposedly with a highly infectious virus. You're not sure, you're not too sure of your own PPE, if it's going to really protect you or anything. And then uh, handling patients would also be a bit intimidating because, um, you have to really examine them up close, um, to take care of your patients, and you have to interact with them to really get a good grasp on their condition and their status. So even if there was a fear back in the time, we had no choice but to go close to the patient, have close face-to-face interactions with them. Um, Especially if you're, even more so if, for example, you had a toxic patient, you had to intubate. Um, you can't intubate the patient from far away. You have to be next to the patient, even if you're not the one intubating the patient yourself. You have to be, as the internal medicine resident on duty, you have to be the one really guarding the patient, really monitoring them, watching for any signs of deterioration. They can deteriorate any moment. Um, and then you're the one inserting, for example, the NGT of the patient. When you insert an NGT, you have to be really up close to the patient and everything. Handling all these bodily secretions and fluids as well. Uh, so yes, at the very start of COVID, it was very scary. It's intimidating, especially I was a first year, beginning in my first year of medical residency, and I didn't know how to handle toxic patients as well. Uh, but compared to now, the COVID ward currently, it's a completely different feel from when it first started. Yes, there's still the fear of being uh, being exposed, to have unnecessary exposure, to be, to catch the infection. But I guess one part to it is that you're more adept in handling those kinds of situations. You're also more used to wearing your PPE. You're now more aware of the limitations of your PPE and what you can do and what you cannot do in your PPE. At the same time, I believe that, especially, well, I'm not sure about others, but I can speak for my institution. Uh, we're more adept as well in handling COVID patients itself. When we have a protocol, we have a good system going, that once we see certain signs in the patient, we start this medication. We don't wait for things to get worse. We immediately have protocols in place that that work its best by avoiding, the long-term complications or deterioration of COVID.
Would you say the whole experience changed you as a doctor? Like from when you entered into residency and now where you are right now?
I can't say for sure that it was just the COVID experience that changed me. Probably just the residency experience itself changed me, and it just so happened to be in the year of COVID, so I guess it was more special in a way. But definitely residency has had I guess the most significant impact in my life because um, residency will really be your life. If you enter residency, especially at the very start of residency, it's going to be your entire life. So, uh, okay, I can't speak for all the specialties, but for sure, for if you enter internal medicine, it's going to be your entire life. Kind of like when you first enter medicine. When you first enter medicine as a medical student, medicine will also be your entire life for a while until you realize how to adjust and adapt. Then you can fit in other things in your life, like hobbies and etc. So yeah, because of residency, there's been a tremendous growth. I feel like I had a lot of growth uh, in my in a lot of growth as a physician. Clinically, having a better clinical eye, seeing patients.
Since you talked about getting into med school, let's go flashback. Let's go all the way back. How was your pre med years?
My pre-medical course was BS psychology, and I took it in the University of Santo Tomas. Uh, I did that to get into my dream school, which was also University of Santo Tomas Medicine. Yeah, supposedly there's an easier track if you're coming from UST. So I went into BS psychology. Um, so uh, BS psychology was probably not the best choice for a pre-med. Just to put it straight and put it out there, it's not the best course for pre-med. It did help me in a couple of subjects, maybe like neuroanatomy. I was more familiar with neuroanatomy and perhaps behavioral medicine. But, but even if you took those subjects for years back in pre-med, when you enter med school, you take it for like one one session, like one class, and 2 years of your pre-med's gone. That's it. You have to move on to something new. So uh, what I learned generally is that your pre-med is helpful, but in the end, doesn't really matter in the long run because eventually you and all your classmates are going to be equal. You're all going to you're all going to have a hard time together in med school. You're all going to have to learn and adapt to new things together. So it's up to you on how well you adapt. I think the best thing that happened because I came from BS psychology is that I felt so unprepared for med school. I think other classmates who came from better pre-meds like medtech and medtech, pharma, or what you call it, physical therapy. I had some classmates who were a bit more familiar with the subjects. They were a bit more complacent handling the subject for the first time. I, on the other hand, was so scared, was so intimidated that I did not allow myself to be complacent at all. So I think that fear, because knowing that I came from a quote unquote weaker pre med, helped me uh, become more focused in med school. Like I felt like I had to compensate more rather than be complacent, which I think saved me.
To all the viewers out there coming from a quote unquote weaker pre med, do not be afraid. Doc Ramon went through it all, and as he said, the weakness that you feel can become a strength if you know how to use it. Since you talked about the strategy of picking a med school with pre med courses, how would you say is the success rate of people doing the same thing?
Okay, I can't say for sure about other schools. Okay, I don't know how it is, for example, in PGH or whatever. But in UST, that's what was endorsed to me by my seniors and my parents as well, who took UST medicine. Um, they endorsed to me that they prefer getting students from their own institution. Um, I think it's fairly common, but I can't speak for other institutions. Uh, Yeah. Supposedly, it's what I heard was that you have to be like uh, an a top notcher, or you have to be you have to really excel from another school, or have great connections from another school to enter UST. If I mean, if you're coming from an outside school, you have to be at the top of your batch or something. And I was never really top of anything growing up. I was never the top of my class growing up. I had average to at best above average grades. Just that. I was never that ambitious with grades in the first place. So I thought it'd just be safer for me to enter my pre-med course in UST, and then hopefully that'll give me an edge in entering UST Med itself.
For sure, you had a favorite subject and you had a dreaded subject. Would you like to elaborate on that, Doc Ramon?
I had a few favorite subjects. One of my favorite subjects before was physiology. Like each time I came into physiology, I was really always super interested in the topic. It was not easy. Physiology is not easy, but for me, I had a ton of fun learning about the system of the body. Like I was just constantly amazed. Like, oh, I love the human body. It's amazing how God made the human body. So that's why even though I didn't get the highest grades in physiology, but it was one of my favorites definitely. And then I felt like I did well enough in physiology just because I enjoyed it. Like even though it was hard, I remembered certain concepts just because I enjoyed it. And in terms of most dreaded, oh, I had a few. Mostly subjects that I really didn't want to deal with, like in the future. Like one was probably I almost failed dermatology. I was really bad in dermatology. Like all these rashes and skin lesions to me just all look alike. I studied it so hard. I did not let it go. I didn't I didn't I wasn't complacent. I just really struggled in dermatology, looking at all the lesions and whatever. And I was just personally not interested in the topic. So it was very struggle. I also did not enjoy uh, gynecology. For me, it was I didn't I didn't have low grades in gynecology, but I did not understand it. In all honesty, I understood it enough to get good grades to pass. Like I didn't have low grades. I had just enough good grades. I had pretty good grades, but it it was not something I could relate to. You could put it at that. And I never felt like I'm going to handle this in the future.
Do you have any tips for those who are currently medical students right now? Like how would what would help them get through the subjects they don't like?
Okay, though for me, the only way I really got through med school, well, one thing that really helped me get through med school was that, especially going through the hard subject, was that I was really good friends with like a with a with a cum laude. I was really good friends. My seatmates were really smart, and I loved them. I really loved them. They'd really teach me. They'd help me out. Especially in med school, tulungan na naman eh. Tulungan naman yun eh. You have to know where you're weak. It's very rare. You have to be some kind of genius to be good at all the subjects. So the subjects that you're weak at, look for someone who's good at that subject, and they can explain it to you in simple terms. For me, the aside from asking help from smarter friends or someone who understands the subject better, is that once you do understand the subject a bit more, what I try to do is that I try to see how I'm going to use this in the future. Like, how will there be in any situation in the future where I could use this information? And most of the time, yes, there's some kind of situation where you could probably apply this information, apply this knowledge, and try to see its significance. And then hopefully that will help you remember those concepts for your exam.
Was there any event, person, or like place that helped you decide on what residency you wanted to take?
From the very start, okay, I wanted to enter medicine from the very from the very start because my parents were doctors, and uh, my mom is an ophthalmologist, my dad's a cardiologist. Uh, and no offense to my mom, but I always looked up to my dad. I always looked up to my dad on how he took care of me whenever I was sick, or not necessarily when I was sick, or when I had any weird symptom in my body, like like my stomach's painful or whatever. He'd always he'd always comfort me like really well. Like I never felt scared. I had a weird symptom in my body. If my dad said I'm fine, I just believed him because he was so confident to say that I was fine. Um, and he would explain to me basic physiology growing up. I didn't understand, actual physiology, but he'd simplify it really well for like a kid to understand basic physiology of the body. That no, your foot is painful because there's certain. I can't remember how he explained to me swelling as a kid, but he explained to me swelling pretty well, and I understood it for the rest of my life. And when I entered med school, and I took physiology for the first time, the subject physiology, and eventually internal medicine, I realized these were the things my dad was teaching me since I was a kid. And because he taught it to me so well, I felt like I was more inclined to that. And uh, I felt comfortable with the subject of internal medicine. And I felt like that's what I also wanted to get into. I guess, yeah, looking up to my dad, and actually all the, not just my dad, but all of the professors I had in med school who were the majority of the professors I looked up to were all from the internal medicine specialty. A lot of pulmonologists I looked up to, a lot of cardiologists, a lot of nephrologists. They were all from internal medicine. So I wanted to be like them, more or less. They're my idols.
Definitely had a lot of idols. But Dr. King, if you're watching, please don't dislike this video. Roman, what would you say would be qualities or like prerequisites before you get into internal medicine? Like, do you have to be good at memorizing guidelines? Do you have to memorize all the formulas?
Well, if you happen to be good at memorizing guidelines, then that's I'm happy for you. That's good for you if you're good at that. But personally, I'm not a great memorizer or anything. Uh, what I would recommend for anyone who's aspiring to enter internal medicine was, there used to be this. I used to have this misconception that you had to be some kind of genius to enter internal medicine because there's a lot of analysis involved. There's a lot of different cases you have to handle. You have to really think about each case you handle holistically. Look at the entire person, uh, which which would make you assume that you need to be really smart, which is, I guess it's true, but uh, it's more of a clinical eye, and it's something more that you could actually be trained in to learn how to handle these patients. So for me, what's more important in internal medicine is actually grit and perseverance and like commitment in the specialty that you took in. Um, I don't. I have not heard yet of residency of internal medicine in any hospital that's claimed to be easy. It's known to be a toxic residency. I'm pretty sure no one has thought of it to be a benign residency. But uh, once you enter it, yes, this specialty is going to push you to your limits again and again and again, especially in your start. I remember back in my second month of residency, I remember every time I'm from duty, I felt like I was pushed to my limit. Every every 3 days, I was pushed to my limit, and then that limit would just keep uh, getting larger and larger. I was able to uh, handle and endure more things as time progressed, and things did not get easier, but you had to learn how to get better. So uh, the residency is going to test you really, going to test you and ask you not just questions about your patient, but questions about yourself. Like, why did I enter this residency? Was it worth it? Uh, why am I even here? Am I even making enough money? Or so yeah, you really need commitment. You need grit and commitment to get through this, and then uh, you need to that grit and commitment is going to teach you as well how to love your specialty and love your patients and love what you do. So for me, though, if you're really sure, like not just 100% sure, like 200% sure that you want internal medicine, then go for it. Yep. As long as you're sure, then I have no objection to you entering that specialty.
Definitely, you need 200% to finish internal medicine for any residency for that matters. Since you practice in a private hospital and they say that private hospitals don't have a lot of patients as compared to public hospitals, how would you like to comment on this, Doc Ramon? Like, do you think you have enough cases, or do you think you have enough experience with patients?
I've heard of that plenty of times. Um, that public hospitals have a lot more cases. I, I don't want to comment about other institutions, but I can definitely say that the institution I'm in, a lot of people have contested that the amount of patients that my institution has as a private hospital rivals a lot of public hospitals. Like the amount of cases there is a lot. Like it can boast to have like a ton of patients. It really boasts to have that, which is true. We handle a lot of patients. Actually, we have a lot of residents. We have a lot of internal medicine residents on board just because to handle the large volume of patients that we have. This was especially true pre-COVID. Pre-COVID times, we had a ton of patients. Like my goodness. Um, Actually, that's the hardest thing about like from my hospital is actually just handling the sheer volume of patients. It's hard to absorb. It's hard to absorb anything when you're just trying to get through the day, trying to see all your patients. That's how many. That's that's how much patients that we have. But during COVID, um, of course, like all institutions, there was a drop in cases. But despite that, like immediately once patients started to come back in, it kind of filled up again. The only reason why we're not able to fill up all of our wards was that um, sadly we had a lack of nurses. We never had a lack of patients. We had a lack of nurses. That's why we couldn't open up all the wards. Um, the the difficulty and the problems during COVID, um, of course, uh, needed extra benefits for our staff, for both the medical and non-medical staff. So of course they would be expecting, hazard pay or these extra benefits or the sheer fear of entering work and and being contaminated or infected by patients, and you go home. I guess that's another thing that the staff was worried about. We lost a lot of good nurses. That's why we didn't have full capacity. Until now, we don't have full capacity because we lost a lot of nurses. We're hiring more nurses again now, just so that we can accommodate all of the patients that we have. But so in terms of cases, no, we never. I don't think we ever had a uh, lack of cases. Never. We even have a large amount of the COVID patients. They come to our institution as well.
Kind of boils down to where exactly the private hospital. Like, it's not a general rule that if it's a private hospital, all you have little patients. Yeah. So from what you said, I definitely think it depends really on the specific hospital.
Yeah, I know some hospitals had a harder time getting cases, like especially if they were not, especially now during the pandemic, they are not as uh, readily equipped to handle the pandemic. They weren't as ready equipped to handle COVID cases. So it took them a while before they reopened and were able to accommodate patients again. I'm very thankful for my institution where responded very well to the pandemic.
So I always ask this question to the on my guests on the channel. So if you had three things as an internal medicine resident and you had a ward in a deserted island where you had nothing else, if you only had three things, Doc Ramon, what would you bring to that ward?
Okay, I guess one would be my stethoscope. Okay, two would be uh, my cell phone with mobile data.
Hopefully there's signal.
Yeah, if there's signal, definitely I read my cell phone and mobile data. I'm going to check the guidelines. I'm going to check the up to date app and help me out handling these patients. Can I bring a person?
Sure, why not? That's a new way to answer the question. Go ahead.
Yeah. Okay. I know a person's not a thing, but if I had if I had a really good a nurse with me, a really good nurse with me, I'd really, I really am reliant on my nurses. They're such a blessing, to be honest. There are a lot of things that I can't do without a good nurse. Like simple. If I want to give an antibiotic, simple diluting the antibiotic with with certain the diluents like NSS, PLR, whatever. I'm not, as I said earlier, I did not come from a nursing pre-medical course. So if I had a good nurse, then probably I would survive.
Definitely a different way to answer. Brilliant, Doc Ramon, and his unique answer. So since you were talking about up to date, the apps, and the things we have on our phone, compare them to the book. What would be their downsides and their upsides?
For internal medicine, our Bible is
Yes.
Harrison's. Is so for we still read Harrison's for sure. Uh, Definitely because most likely our board exam in internal medicine will be based on Harrison's. So no matter what up to date says or whatever app says, if it's not in Harrison's, probably they would or the other guidelines. Uh, you're probably not gonna take it from there. You're gonna have a lower grade in your exam.
Yeah.
Your goal for residency is to graduate. Honestly, that's your goal. Your goal is to graduate. So you need to graduate. You need to study the source, which is Harrison, which is the book. And the book is great to get into detail of certain diseases, um, and to understand certain pathophysiologies, and that a lot of uh, apps would not have. Like up to date is great also for explaining pathophysiologies and for easy access and for latest guidelines and certain guidelines and algorithms. But um, yeah, it's still best to have both hand in hand. Sometimes up to date would or other guidelines or the newer guidelines would not coincide well. I would not have the same management compared to that of the book. And then, but some of these guidelines are in the newer apps were based on studies on specific kinds of populations as well. So you have to also consider that you have to know where these apps or whatever are basing their management on. The book, though, it's a bit more, I guess, safer in a way, but it's also not as dynamic. Gets it's hard to explain. You have to take. You have to. I think. Yeah, honestly, you have to read both to handle your patients. You have to read both and then try to apply it to your patient. What seems to be the best management at the time, and then base it clinically. If this is going to treat each patient special as a own unique case, try to uh, customize it best to your patient. But for your board exams, definitely you have to read your book.
To the students who don't read their book, you are going to read your book eventually. If not now, then when you get to your specialty in the future. Being in internal medicine, there's a unique aspect of having a lot of attending physicians and from different subspecialties, right? How do you deal with this unique aspect of having so many quote unquote bosses who have different uh, subspecialties?
Oh yeah, that's definitely that's a good question because it's very actually hard to handle a lot of like quote unquote bosses from a lot of specialties, especially uh, that I work in a private hospital. A lot of your decisions have to also be conferred with the attending physician. You can't. There's certain management that you have to get the approval from a lot of doctors before something can be done. So especially as a first year medical resident or as the medical resident there, you have to coordinate with all of them um, to make sure, like for example, something as simple as removing a Foley catheter of a patient. Like the infectious disease service would say, "Can you please remove the Foley catheter because it's too long already in the patient. It's been there for a week or two already, and could be causing an infection, source of infection of the patient. Is it okay we remove it? If okay with the service of nephrology, you have to coordinate with nephrology is also your boss, and then say, no, we still need that Foley catheter, so let's just reinsert another one or something. That's a very simple case, but sometimes they happen to argue on management. Like like for example, infectious disease will start steroids. Like for example, in COVID, give dexamethasone, and then endocrinology is not informed that they're started on steroids. Then suddenly their blood sugars hitting and rising, and they're not informed. And suddenly they get mad at each other, and suddenly it's all your fault as the internal medicine resident for not informing them immediately or whatever. It's always basically everything is your fault. As the first year medical resident, everything is your fault. You just gotta accept it. But yeah, it's definitely a challenge. You have to anticipate each and every aspect, each and every specialty, that this is what they want, this is what they want, this is what they don't want. So I guess them arguing also teaches you different perspectives of each subspecialty. Like, why are they arguing in the first place? Like, what do they want? So yeah, just by those simple problems, you're understanding more and more about how one system of the body is interacting with the other system of the body. You know, it's through those very simple problems. But yeah, you could appreciate it later on. But yeah, handling all those different bosses is very challenging because you're basically handling different systems that they are treating at the same time.
In the end, it's about learning the art of putting together all the specialties into a holistic practice.
Yeah, yeah, I suppose.
Since we're on the topic of subspecialties, do you have any ideas for the future? What subspecialty you want to take?
So yeah, I'm still in my second year of internal medicine. I'm still going to rotate in the different subspecialties. So far, I guess you know, uh, I guess one of my favorite subjects ever since and until now is still cardiology, and that's still one of my top picks. Like my dad's a cardiologist as well. Second to that, I'm not too sure. There was a good time I was heavily also considering pulmonology. Um, some I'm also appreciating others like infectious disease and such, but I'm not too sure yet. It's for me too early to say.
Hey everyone, so if you've been following the channel, you looked forward to these games, and today we're gonna play a game with Dr. Ramon. It's called Clinic or Comic. So I'm gonna mention to him a superhero since he loves superheroes, and he's gonna tell me if there may be a disease that actually can make you become like this superhero. So he has to pick whether it's clinic or comic. Alright, Ramon, let's go. So for our first hero, let's start it simple. Mr. Fantastic, clinic or comic? is there any diseases that you think might make
I don't
somebody
know.
like
Well,
Mr. Fantastic?
you can think of something like the Ehlers-Danlos syndrome. You
Yeah,
remember?
that's correct. So
Okay.
Ehlers-Danlos syndrome or
Okay.
EDS is a group
Okay.
of relatively rare genetic disorders where people become very stretchy. So they have stretchy skin, their joints are super mobile, and basically they become, but not as stretchy as Mr. Fantastic, of course.
I'm just happy I got to answer that question, man, from duty right now.
So you are sleep deprived, but yet you still know your rare diseases. All right, next one. Another superhero from the Fantastic Four, The Thing or Ben Grimm. Clinic or comic?
Oh yeah, there's this. Oh no, I can't remember the term, but if talking about those rare diseases, there's definitely a disease where you can have a like is it hypercalcium in the bones or something where um not too sure, but yeah, there's something like that where your bones are way too hard. I guess the opposite of brittle bone disease. I remember
Again,
right now.
definitely Doc Ramon is quite fantastic because he pretty much got it. So fibrodysplasia ossificans progressiva, or Stoneman's disease. So it's a rare connective tissue disorder where where people have hardening, or what we call ossification. So their skin or their joints become bone-like, and usually it's on the outside. So they end up looking somewhat like the Thing. Next one, clinic or comic? Wolverine.
Yeah, I'm not too familiar with instant regeneration diseases. Let's see. Hmm. Or any
Make
disease
you have claws.
yeah, protrude claws from your hands. Let's see. Yeah, no, I can't think of anything right now.
Dr. Ron got it
No,
again
I can't think
right.
of
So
anything.
definitely, as of now, we still don't know anybody with hyperregeneration in
Yeah, because
humans.
yeah, because I don't think that'll be a
Yeah.
disease at all. That sounds like such a great benefit. No, although if we're talking about like comics and regeneration, technically Deadpool has
Yeah.
something like that. He uses his cancer cells as reproducing cancer cells to as it's like it's artificial regeneration rather than just pure regeneration from
Mhm.
Wolverine. So if he could duplicate his cancer cells in a way,
Maybe in the future.
it could kind of be like
Yeah.
regeneration.
Maybe in the future we'll
Yeah, I
see
don't know.
a new technology that will help people regenerate lost limbs and body parts. We have our last one. So Dr. Morbius, the vampire.
Oh yeah, yeah.
So
Okay.
clinic or comic?
Oh my gosh. I guess that's clinic because vampires are I think based on hemophiliacs, right?
And yes, the Roman got it. There are a group of diseases called porphyrias. So porphyria cutánea tarda, uh, or a skin condition which causes people to be hypersensitive to light. And there's actually
Okay.
another disease that could make you have vampire-like features, or hypohidrotic ectodermal dysplasia. So people with this disease have the conical teeth, like sharp teeth, and they also have sensitivity to heat and light since their skin can't sweat. Definitely, Morbius can be a real person. And fun fact, he is also a medical doctor.
I read somewhere before that people thought like one of the myths of vampires also
Hemophil-
the hemophiliacs because they would
they need to
constantly
consume
need
blood, right? Yeah. So definitely a lot of our superheroes are based on real conditions that people see. Yeah, strange diseases and urban legends. So before we end, do you have any last words or messages for aspiring internal medicine doctors?
As I mentioned earlier, it's not an easy specialty, but definitely um, a lot of people can say it's a fulfilling specialty because at the end of the day, maybe not necessarily the day, but at the end of your training or after, at the end of your training, you're really going to appreciate um, being able to take care of the patient from start to finish, where like you handle a patient really holistically. um, if you love talking to people, you love seeing them, you love taking care of them, definitely it's a good specialty that you can consider. Looking at all the different aspects of a patient or their disease, internal medicine has that benefit. I mean, other specialties have that too, but for sure internal medicine would have that in spades. um, so it's a very fulfilling specialty.
Thank you for watching. Please like and subscribe. If you want to see another specialty video, I'll put the link right here. And I want to hear from you in the comments what specialty you want me to cover next.